Do you know about importance of iron? Let's start with importance of iron. Iron is essential for human life. It is at the core of hemoglobin, which transports oxygen to the body via red blood cells. Deficiency of iron eventually leads to anemia, which means a low red blood count. Iron deficiency and anemia can lead to fatigue, exercise intolerance, decreased immunity, adverse outcomes during pregnancy, and a whole host of other problems that are still being studied. In population with the adequate food intake, pregnant and lactated women are at the highest risk for iron deficiency, along with small children. In population with inadequate access to food, iron deficiency is common. On the other hand, excessive amounts of iron are stored in body organs where the iron can cause damage. An example of this is hereditary disease called hemochromatosis, in which iron is deposited in the liver, the heart, and other organs. Treatment of this disease includes removal of blood to decrease the excess iron. Older people may also accumulate excess iron from the diet or supplements, which may increase their risk of certain chronic illness. While there is control system in the body regulating iron absorption, that can delay or mask some of the problems with iron deficiency or excess. A deficiency of iron will eventually produce the symptoms, as will a chronic excess. Iron has the knack of switching back and forth between two ionic states. In the reduced states, iron has lost 2 electrons and has a net positive charge of 2. It is known as ferrous ion. In the oxidized state, iron has lost a third electron, has a net positive charge of 3, and is known as ferric ion. Because ferrous ion can be oxidized to ferric ion and ferric ion can be reduced to ferrous ion, iron can serve as a cofactor to enzymes involved in oxidation reduction reactions, so widespread in metabolism that they occur in all cells. Iron is also required by enzymes involved in making of amino acids, collagen, hormones, and neurotransmitters. Iron forms a part of the electron carriers that participate in the electron transport chain. In this pathway, these carriers transfer hydrogen and electrons to oxygen, forming water, and in the process make ATP for the cell's energy use. Most of the body iron is found in two proteins, hemoglobin in the red blood cells and myoglobin in the muscle cells. In both, iron helps accept, carry, and then release the oxygen. The body conserves iron because it is difficult to excrete iron once it is in the body. Balance is maintained through absorption. More iron is absorbed when stomach is empty and when the stores are empty, and less is absorbed when stores are full. Special proteins help the body absorb iron from food. One protein called mucosal ferritin receives iron from food and stores it in the mucosal cells of the small intestine. When the body needs iron, mucosal ferritin release some iron to another protein called mucosal transferrin. Mucosal transferrin transfers the iron to another protein, blood transferrin, which transports the iron to the rest of the body. If the body does not need iron, it is carried out when the intestinal cells are shed and excreted in the feces. Intestinal cells are replaced about every 3 days. By holding iron temporarily, these cells can either deliver iron when the day's intake falls short or dispose of it when intakes exceed needs. Both iron deficiency and iron excess can be damaging. There is a controlled mechanism in humans to try and maintain a correct iron balance. Ingesting iron is a pull in the intestinal tract. When there is a low amount of iron in the body, more iron in the pool will cross into the cells lining the intestine. A relatively newly discovered peptide called hepcidin regulates the export of iron from the intestinal cells, as well as iron stored in liver cells or macrophages. Hepcidin degrades ferroportin, the protein that transports iron out of cells. Hepcidin is also believed to regulate the amount of iron that enters intestinal cells, called enterocytes. Ongoing study of hepcidin is increasing the understanding of iron homeostasis in the human body and will lead to better ways to diagnose and treat iron disorders. Iron is transported out of cells and into the circulation, eventually to the bone marrow, where red blood cells are made. Iron can also be retained in the intestinal cells attached to ferritin. Approximately 80% of the iron in the body is inside the red blood cells. These cells age and are replaced with new red cells every 120 days. Iron is stored primarily in the liver and spleen as hemosiderin, as well as in individual cells bound to ferritin. Hemosiderin in the liver increases dramatically if there is excess iron. Iron is an element that can exist in a number of oxidative states, usually ferric or ferrous, which have different degrees of oxidation. Iron is most commonly bound to the oxygen, nitrogen and sulfur. Its unique chemical properties make it useful in a wide variety of chemical reactions. In the human body, reactions involving iron, including oxidation reduction reactions, oxygen transport and storage, and transfer of electrons. In the humans, iron is contained in proteins. There are the non-enzymatic proteins hemoglobin and myoglobin, enzymes containing iron, enzymes containing heme iron, and a group of enzymes that contain iron in different forms. Hemoglobin and myoglobin transport oxygen. Iron sulfur enzymes are involved in energy metabolism. Iron heme enzymes transfer electrons associated with a number of cofactors. Oxygen transport is the best known and most important functions of the iron. Hemoglobin is a protein with two identical subunits, each of which has an iron-containing compound that can bind with oxygen. Hemoglobin transports oxygen from the lungs to the rest of the body. It picks up oxygen from lung capillaries and transports it to the capillaries in tissue throughout the body. Iron's primary mechanism of action is its ability to bind oxygen as well as release it. In peripheral tissues, higher concentration of carbon dioxide and lower pH favor releasing of oxygen from hemoglobin. Iron is necessary to make hemoglobin, and hemoglobin is necessary to make red blood cells. Myoglobin has a single subunit and transport the oxygen from red blood cells to the inside of other cells, especially to mitochondria. The powerful and powerhouses of the cell. Iron absorption depends in part on its sources. Iron occurs in two forms in foods, as heme iron, which is found only in foods derived from the flesh of animals, such as meats, poultry, and fish, and as non-heme iron, which is found in both plant-derived and animal-derived foods. On average, heme iron represents about 10% of the iron a person consumes in a day. Even though heme iron accounts for only a small proportion of the intake, it is so well absorbed that it contributes significantly iron. About 25% of heme iron is absorbed. By comparison, only 17% of non-heme iron is absorbed. Depending on dietary factors and the body's iron stores. In iron deficiency, absorption increases, and in iron overload, absorption declines. Meat, fish, and poultry contain not only the well-absorbed heme iron, but also a factor. What is the factor? The factor called MFP factor, that is meat, fish, and poultry factor, that promotes the absorption of non-heme iron from other foods eaten at the same meal. Vitamin C also enhances non-heme iron absorption from foods eaten in the same meal by capturing the iron and keeping it in the reduced ferrous form, ready for absorption. Some acids and sugars also enhance non-heme iron absorption. Some dietary factors bind with non-heme iron, inhibiting the absorption. These factors include the phytates and fibers in soy product, whole grains, and nuts, oxalates in some vegetables, calcium and phosphorus in milk, the EDTA in food additives, and the tannic acid in tea, coffee, nuts, and some fruits and vegetables. Foods and factors that inhibit the non-heme iron absorption included the phytates and fibers, which found in grain and vegetables, oxalates, which found in spinach, beets, and calcium and phosphorus, which found in milk, tannic acid and other polyphenols in the tea and the coffee. These all factors inhibit the non-heme iron absorption. Many dietary enhancers, inhibitors, and their combined effects make it difficult to estimate iron absorption. Most of these factors exert a strong influence individually, but not when combined with the others in a meal. The impact of combined effects diminishes when a diet is evaluated over several days. When multiple meals are analyzed together, three factors appears to be most relevant. MFP, which is the meat, fish and poultry factor, and vitamin C as enhancers and phytates as inhibitors. About 18% of dietary iron is absorbed from mixed diets and only about 10% from vegetarian diets. Vegetarian diets do not have the benefit of easy to absorb heme iron or the help of MFP in enhancing the absorption. But even the absorption of non-heme iron is low. In addition to the dietary influences, iron absorption also depends on an individual's health, stage in the life cycle, and iron status. Absorption can be as low as 2% in a person with GI disease or as high as 35% in a rapidly growing healthy child. The body adapts to absorb more iron when a person's iron stores fall short or when the need increases from any reason such as pregnancy and lactation. The body makes more mucosal transferrin to absorb more iron from the intestines and more blood transferrin to carry more iron around the body. When the iron stores are sufficient, the body adapts to absorb the less iron. Blood transferrin delivers iron to the bone marrow and other tissues. The bone marrow uses large quantities to make new red blood cells, whereas other tissues use less. Surplus iron is stored in the protein ferritin, primarily in the liver, but also in the bone marrow and spleen. When dietary iron has been plentiful, ferritin is constantly and rapidly made and broken down, providing an ever-ready supply of iron. When iron concentrations become abnormally high, the liver converts some ferritin into another storage protein called homocidrin. Homocidrin releases the iron more slowly than ferritin. By storing excess iron, the body protects itself from iron acts as a free radical, attacking cell lipids, DNA and proteins. The average red blood cells lives about 4 months. Then the spleen and liver cells remove it from the blood, take it apart and prepare the degradation products for excretion or recycling. The iron is salvaged. The liver attaches it to blood transferrin, which transports it back to the bone marrow to be reused in making new red blood cells. Red blood cells live for only about 4 months. The iron recycles through each new generation of cells. The body loses some iron daily via the GIT tract, and if bleeding occurs in blood, only tiny amounts of iron are lost in urine, sweat, and shed skin. Iron deficiency is the most common nutrient deficiency, affecting more than 1.2 billion people. In developing countries, almost half of the preschool children and pregnant women suffer from iron deficiency anemia. Iron deficiency is less prevalent but still affects 10% of the toddlers, adolescent girls, and women of childbearing age. Preventing and correcting the iron deficiencies are high priorities. Some stages of the life both demand more iron and provide less, making deficiency likely. Women in their reproductive years are especially prone to iron deficiency because of repeated blood losses during menstruation. Pregnancy demands additional iron to support the added blood volume, growth of the fetus, and the blood loss during childbirth. Infants and young children receive little iron from their high milk diets, yet need extra iron to support their rapid growth. The rapid growth of adolescents, especially for males, and the menstruational losses of females also demand extra iron that a typical teen diet may not provide. An adequate iron intake is especially important during these stages of the life. Bleeding from any side incurs the iron losses. In some cases, as in an active ulcer, the bleeding may not be obvious, but even small chronic blood losses significantly deplete the iron reserves. Treating the ulcer resolves the iron deficiency. In developing countries, blood loss is often brought on by malaria and parasites infection of the GIT tract. People who donate the blood regularly also incurs the losses and may benefit from the iron supplements. Menstrual losses can be considerable as they tap the women's iron stores regularly. Iron deficiency develops in stages. This provides a this provides us how to detect these stages. In the first stage of iron deficiency, iron stores diminish. Measures of serum ferritin reflects iron stores and are most valuable in assessing the iron status at this earliest stage. The second stage of iron deficiency is characterized by a decrease in transport iron. Serum iron falls and the iron carrying the protein transferrin increases, an adaptation that enhances the iron absorption. These two measures can determine the severity of the deficiency. The more transferrin and the less iron in the blood, the more advanced the deficiency is. Transferrin saturation. The percentage of transferrin that is saturated with iron decreases as iron stores decline. The third stage of iron deficiency occurs when the lack of iron limits hemoglobin production. The hemoglobin precursor, that is erythrocyte protoporphyrin, begins to accumulate as hemoglobin and hematocrit values declines. Hemoglobin and hematocrit tests are easy, quick and inexpensive. So they are the tests most commonly used in evaluating the iron status. Their usefulness is limited because they are late indicators of iron deficiency. Other nutrient deficiencies and medical conditions can influence their values. Iron deficiency and iron deficiency anemia are not the same. People may be iron deficient without being anemic. Iron deficiency is basically the depleted body iron stores without regard to the degree of the depletion or to the presence of anemia. The term iron deficiency anemia is the severe depletion of iron stores that results in a low hemoglobin concentration. In iron deficiency anemia, red blood cells are pale and small. They can't carry enough oxygen from the lungs to the tissues. Without adequate iron, energy metabolism in the cells falters. Result is fatigue, weakness, pallor, headache, apathy, and poor resistance to the cold temperature. Hemoglobin is the bright red pigment of the blood. The skin of a fair person who is anemic may become pale. In a dark-skinned person, the tongue and eye lining, normally pink, will be very pale. The fatigue that accompanies the iron deficiency anemia differs from the tiredness a person experiences from a simple lack of sleep. People with anemia feel fatigue only when they exert themselves. Iron supplementation can relieve the fatigue and improve the body's response to the physical activity. Iron deficiency without clinical signs of anemia impairs the physical performance. Highly trained athletes, both male and female, need more iron than those who do not exercise. They may be losing more iron in the stool or urine, or the red cells may be rupturing in the feet of runners. More athletes have iron deficiency anemia than occur in the general population, especially female athletes. This is likely due to a variety of factors, from decreased consumption of iron to increased losses. Anemic athletes perform poorly. Iron status need to be monitored and appropriate supplements given to the athletes. People with restless leg syndrome have an uncontrollable and distressing urge to move their legs, severe enough to interfere with the sleep. Many studies have found a high prevalence of iron deficiency in patients with this problem. Iron testing is recommended and treatment with iron given if iron is low. Iron is the key to oxygen transport, even the patients without iron deficiency, anemia, but with low iron stores may have more symptoms from heart failure. Intravenous iron given to the patients with the chronic heart failure improve the many symptoms, functioning and quality of life, even in those who were not anemic. Red blood cells are affected and anemia is diagnosed. A developing iron deficiency affects the behavior. Even a slightly lowered iron levels, energy metabolism is impaired and neurotransmitters synthesis is altered, reducing physical work capacity and mental productivity. Without the physical energy and mental alertness to work, plan, think, play, sing, or learn, people simply do these things less. They have no obvious deficiency symptoms. They just appear unmotivated, apathetic, and less physical fit. Work productivity and voluntary activities decline. Many of the symptoms associated with iron deficiency are easily mistaken for behavioral or motivational problems. A restless child who fails to pay the attention in class might be thought contrary. An apathetic homemaker who has let housework pile up might be thought lazy. No responsible dietitian would ever claim that all behavioral problems are caused by nutrient deficiencies. But poor nutrition is always a possible contributor to the problem, like these. When investigating our behavioral problems, check the adequacy of the diet and seek a routine physical examination before undertaking more expensive and possibly harmful treatment options. The brain is rich in iron, but the pattern of iron location in the brain varies from infancy to adulthood. Iron is needed in order for the spinal cord and the cerebellar folds in the brain to have normal myelinization. The development of a protective covering of myelin. Myelinization is the development of protecting covering of myelin. Iron deficiency may cause a delay in the maturation of motor control in childhood as well as affect the behavior. It may also cause cognitive defects. The effect of iron deficiency on the neurotransmitters in the brain indicates that it may affect the GABA metabolism and dopamine. An effect on serotonin and dopamine is also observed. Their synthesis is decreased when there is iron deficiency. This can lead to behavioral and cognitive alterations. There may be a critical time period during which human brain is susceptible to the iron deficiency and damage occurs that cannot be corrected with iron later on. There are indications that infants between the 18 to 15 months old may be susceptible to the damage from low iron, which is irreversible. It seems possible that infants and children who are iron deficient up to age 2 years will have permanently damage that can include motor control problems, behavioral problems, and cognitive deficiencies. Older children may have the same type of problems that can be resolved with adequate iron intake. Deficiency of many other nutrients negatively impacts the brain functions when it occurs early in the development. Iron deficiencies may be accompanied by other deficiencies. It is very difficult to prove that the low iron alone is responsible for abnormalities or deficiencies. Anemia itself depresses the mental processes and brain functions. It is very difficult to say if the anemia of iron deficiency is causing the problem, or if a lesser iron deficiency without anemia would have the same effect. Iron deficiency is a well-known problem. It can occur because of increased loss of iron in menstrual blood from bleeding in the intestinal tract or from major trauma with the blood loss. It can also occur because of insufficient iron in the diet or decreased absorption of iron. Most of the time, iron deficiency occurs slowly when there is not enough intake of the iron to the balance losses. It is released from the body stores and hemoglobin and red blood cells remain normal. Anemia is an advanced stage of iron deficiency when stores have been used up. A range of symptoms is associated with iron deficiency. Most are likely a direct result of the lack of hemoglobin and the decreased oxygen delivery throughout the body. There may also be effects on the body that are not due to the low hemoglobin, but are rather due to an interruption of the other iron-related reactions. With iron deficiency, the concentration of hemoglobin in muscles drops, which may cause decreased endurance. Myoglobin is similar to hemoglobin, but found in skeletal muscles. Fatigue and lack of energy are prominent, and physical performance is decreased. People with iron deficiency may exhibit pica, which is the desire to eat non-nutrient items such as dirt and ice. A curious behavior seen in some iron deficient people, especially in women and children of low income groups. Pica is an appetite for ice, clay, paste, and other non-food substances. These substances contain no iron and cannot remedy a deficiency. Clay actually inhibits the iron absorption, which may explain the iron deficiency that accompanies such behavior. Visible physical changes include a bluting to the whites of the eye, spooning of the nails, inflammation of the tongue, cracking of the sides of the lip, and a measurable anemia. Iron deficiency leads to an impairment of many of the body's functions, including thermoregulation, mental functions, and immune functions. It can alter insulin sensitivity, drug metabolism, and absorption of metals like cadmium and lead. It can slow childhood development. While the anemia from iron deficiency causes the problem, such as the effect iron deficiency has on the development of mental function, iron deficiency can lead to the complications of pregnancy. Moderate to severe anemia increases the risk of mental death. It also associated with low birth weight and premature delivery. Maternal iron deficiency with the cardiovascular disease when the children grow into the adulthood. The developing fetus will get into at the expense of the mother. Full-term babies of normal weight born to the iron deficient mothers may not have obvious iron deficiency. They still may have decreased iron stores. Premature and low birth weight babies may be iron deficient because they did not have enough time or get enough nutrition from their mothers. People with kidney failure on dialysis often develop the iron deficiency anemia because of iron losses as well as decrease in erythropoietin. Erythropoietin is a hormone secreted by the kidney that stimulates the red blood cells production. Vitamin A deficiency limits the body's ability to use iron. It does not cause actual iron deficiency. Blood can be lost in the intestinal tract because of bleeding from cancer and inflammatory disease of the intestine like the Crohn's disease. Crohn's disease and any other causing journal malabsorption can also cause iron deficiency. Vegetarians can also become iron deficient because the non-heme iron in their diets may not be well enough absorbed. People who have gastric bypass surgery frequently become iron deficient and need supplements, sometimes intravenously. Iron deficiency can be detected before anemia occurs. There are a number of the blood cells that can perform to measure the iron stores. If iron stores are low, supplementation is indicated to prevent the anemia and other symptoms. Iron in food found from both plant and animal sources. Animal proteins and some plants contain heme iron. The iron in heme is bound in a ring structure, such as hemoglobin. Many plant sources offer non-heme iron. Food enriched with iron contains non-heme iron. Heme iron is much more easily absorbed in the intestine. Sources include red meats, chicken and other poultry, fish, shellfish. Natural non-heme iron can be found in many kinds of beans, soya, and soy derivatives like tofu, as well as spinach and raisins. Cereals are often iron fortified, as are many types of bread. Iron absorption in the intestine varies depending on the type of iron, the amount of iron in a person's system, the presence of food or medication in the intestinal tract, and other factors. 10 to 15% of dietary iron is absorbed. The usual diet provides about 6 to 7 milligrams of iron for every 1000 kilocalories. The recommended daily intake for men is 8 milligrams, and most men eat more than 2000 kilocalories a day. So they can meet their iron needs with little effort. Women in their reproductive years need 18 milligrams a day. Vegetarian needs 1.8 times as much iron to make up for the low bioavailability typical of their diets. Because women have higher iron needs and lower energy needs, they sometimes have trouble obtaining enough iron. Women receive only 12 to 13 milligrams of iron per day, not enough until after menopause. To meet their iron needs from foods, premenopausal women need to select iron-rich foods at every meal. Meat, fish and poultry contribute the most iron. Other protein-rich foods such as legumes and eggs are also good sources. An indispensable part of the diet, foods in the meal groups are notoriously poor in iron. Grain foods vary with whole grains, enriched and fortified breads and cereal providing the most iron. Dark green such as broccoli and dried fruits such as raisin contribute some iron. Iron is one of the enrichment nutrients for grain products. One serving of enriched bread or cereal provides only a little iron. But because people eat many servings of these foods, the contribution can be significant. Iron added to foods is not absorbed as well as naturally occurring iron. But when eaten with absorption enhancing foods, enrichment iron can make a difference. In case of iron overload, enrichment can exacerbate the problem. The bioavailability of iron in meats, fish and poultry is higher. In grains and legumes, intermediate and in most vegetables, especially those high in oxalates such as spinach, low. The amount of iron ultimately absorbed from a meal depends on the combined effect of several enhancing and inhibiting factors. For maximum absorption of the non-heme iron, eat meat for MFP and fruits or vegetables from vitamin C. The iron of baked beans, for example, will be enhanced by the MFP in a piece of ham served with them. The iron of bread will be enhanced by the vitamin C in a slice of tomato on a sandwich. Iron from the foods, contamination, iron from non-food sources of inorganic iron salts can contribute to the day's intake. People can also get iron from supplements. Foods cooked in iron cookware take up iron salts. The more acidic the food, the longer it is cooked in iron cookware, the higher the iron content. The iron content of eggs can triple in the times it takes to scramble them in an iron pan. The absorption of this iron may be poor, perhaps only 1 to 2%. But every little bit helps a person who is trying to increase iron intake. People who are iron deficient may need supplements, as well as an iron-rich absorption enhancing diet. Many physicians routinely recommend iron supplements to pregnant women, infants and young children. Iron from supplement is less well absorbed than that from food, so the doses have to be high. The absorption of iron taken as ferrous sulfate or as an iron chelate is better than that from other iron supplements. Absorption also improves when supplements are taken between meals or at bedtime on an empty stomach and with liquids other than milk, tea or coffee, which inhibit absorption. Taking iron supplements in a single dose instead of several doses per day is equally effective and may improve a person's willingness to take it regularly. There is no benefit to taking the iron supplements with orange juice because vitamin C does not enhance the absorption from supplement as it does from food. Vitamin C enhances the iron absorption by converting mo most of the insoluble ferric iron in food to the more soluble ferrous iron, and supplemental iron is already in the ferrous form. Constipation is a common side effect of iron supplementation. Drinking plenty of water may help to relieve this pain. Primary use of iron is to treat iron deficiency. It can also be used to prevent iron deficiency at predictable times. For example, pregnant women need much more iron because they have a larger blood volume, need enough iron for the baby, and also will lose blood during the delivery. 12% of women aged 12 to 49 years will be iron deficient. The recommended dietary allowances for the iron is different between males and female at different ages. The RDA is meant to indicate the amount of a nutrient that will meet the needs of 97 to 98% of healthy people. Many people can get the iron they need from food, especially those who do not have increased need for iron. Healthy infants are born with iron stores to last around 6 months. According to the RDAs, infant ages 7 to 12 months old need 11 milligram of iron a day. Children ages 1 to 3 years need 7 mg a day. Children ages 4 to 8 years need 10 mg of iron a day. From 9 to 13 years, both boys and girls need 8 mg of iron a day. From 14 to 18 years and on. There is a difference between girls and boys. Girls in that age group need 15 mg of iron a day, whereas boys only need 11 mg of iron a day. Between ages 19 and 50 years, when women are menstruating, women need 18 milligram of iron a day. Pregnant women need 27 mg of iron a day, while lactating women need significantly less, 9 mg a day. After age 51, both men and women need 8 mg of iron a day. Babies can absorb iron in breast milk very well. They cannot absorb cow's milk iron, which is low. Cow's milk can also cause intestinal bleeding in babies and should not be given to them. Breast milk and then iron fortified baby food are recommended. People with inadequate sources of quality food can develop iron deficiency, particularly in the groups they need more iron. Worldwide, as many as 80% of the people may be deficient in iron. Pregnant women are often recommended to take the low doses of supplemental iron in the range of 30 mg per day. If iron deficiency anemia occurs, high doses of the iron are necessary. Iron deficiency can be diagnosed by a number of the tests, including serum ferritin levels, transferrin concentration, mean cell volume, and sustainable iron in the bone marrow. Ferritin levels may be the most sensitive indicator of how much iron is still in storage. Low serum transferrin saturation indicates that there is not enough iron to continue to make normal amounts of hemoglobin. Doctors can decide which tests need to be done to evaluate a person's iron status. Then iron supplementation can be recommended if necessary. It is very important not to assume that anemia is caused by iron deficiency. If iron is given to the individuals without iron deficiency, excess iron can accumulate. The most easily absorbed type of iron occurs in the form of ferrous iron. Ferrous sulfate has the most available iron, followed by ferrous lactate and ferrous glucate. A 300 mg tablet of ferrous sulfate has 50 to 60 mg, approximately 20% of available iron. Ferrous gluconate has only 12% iron content. If all the iron is taken at once, less will be absorbed. Most recommend that when treating iron deficiency, the iron should be split up and taken twice a day. A common dose to treat iron deficiency would be 300 mg of ferrous sulfate, 2 times a day for approximately 3 months. Iron is absorbed better when taken with vitamin C. Physicians can monitor the laboratory test to make sure then the iron is absorbed, stores are being replenished, and anemia corrected. It is very unusual, but sometimes in severe cases of iron deficiency, the iron has to be given by injections monitored by a healthcare provider. The safe upper limit for iron according to the Institute of Medicine is 40 mg per day for infants and children up to age 13. Then 45 mg per day is the upper limit for people age 14 to 18 and adults including pregnant and lactating women. The upper limit defines a dose above which most people experience significant adverse effects with iron, usually gastrointestinal. This upper limit will not prevent overload in the patient with the hemochromatosis. Iron supplements frequently cause nausea, vomiting, constipation or diarrhea, abdominal discomfort, and dark colored stools. Dividing up the dose and taking iron with the foods help lessen these symptoms. They also usually decrease with time as the body adjusts to the supplements. High amount of the ingested iron can reduce the iron absorption. Excessive amount of iron are very dangerous. If there is too much iron in the intestinal tract, it can overwhelm any feedback mechanism and will be absorbed. High iron can actually kill cells in the intestinal tract. Vomiting and diarrhea will be followed by the death if a lethal dose of iron is ingested. A one-time lethal dose is in excess of 180 mg per kg, which would be at least 12–1600 mg of iron for an average adult male. Children can ingest a toxic amount if they eat a lot of iron supplement pills. For example, all of 100 pill bottle. There is a true emergency. As recently as 1997, the most common cause of poisoning deaths in children less than 6 years old was accidental iron ingestion. Chronic consumptions of excess iron can cause intestinal symptoms and constipations. This can occur at the doses of 10 to 20 mg per kg, which would be 700 to 1400 mg of iron daily. As a point of reference, most ferrous sulfate tablets contain the 60 mg of the iron. There is also no way for the body to get rid of excess iron. it tends to accumulate in elderly, especially if they continue to eat a high iron diet with lots of red meat and similar foods. Iron from diet alone does not usually cause the iron overload. Supplements are usually involved.